Good afternoon, everybody. Welcome to the third instalment of the Workers' Comp Masterclass. This week's seminar is Tools and Approaches for Retaining Trust and Open Communication with Workers After a Disputed Claim. We're very lucky to have Dr. John Saul and Verity Coulter to speak on this topic for us. Firstly, I just want to deliver an acknowledgement of country. So I'd like to lead an acknowledgement to the traditional custodians of the land on which we work and live today and recognise their continuing connection to land, water and community. We pay our respects to their elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander people here today. Next, I just want to thank our sponsors for the masterclass. We have HWL Ebsworth as our gold sponsor, IIME, Red Health and LKA Group as our silver sponsors. As you would have heard at the start, you're all in listen only mode, which means you are muted, but we do encourage questions. So please use the question panel and send in questions to me that I can put to our speakers. So Dr. John Saul, graduated university in 1983. He travelled around and worked in New South Wales and Queensland before settling back in Lauderdale in 1990 and has been practising as a general practitioner since that time. He has always liked general practice, but with a special interest in health promotion, sports medicine and workers' compensation. Verity Coulter is an occupational therapist with almost 24 years experience. She initially commenced practice with neurological and aged care community rehabilitation in South Australia before moving to Tasmania and worked with the Motor Accidents Insurance Board. She commenced private practice in 2002 and has provided injury management services, functional capacity evaluations, occupational therapy to a wide range of injuries within Tasmania, including both compensable and non-compensable injuries and illness. We're all very fortunate to have them speak to us today, and we'll start shortly. I'll just advise that it is going to be recorded and the link emailed to people the day after, just in case people aren't able to attend or you want to watch it again. And without further ado, I will hand it over to our speakers.
Thank you. John and I have been asked to talk about tools and approaches for retaining trust and open communication after a disputed claim. But I guess we thought it was really important to look at the communication that starts when you first meet an injured worker or their employer or their GP, because unless you have those really basic tenets of communication open at the start, there is absolutely no way knowing you're going to have any communication by the time it gets to a dispute. So I guess, oops. Can I go backwards a couple of slides, please? Yep. So the very basic aspects of communication that you need to address when you first meet an injured worker is you need to very quickly build trust and rapport. You need to be quite clear about what your role is, what the goals of rehab are, and you need to be able to provide that consistent message. And I guess from a rehab perspective, quite often than not, you have never met the worker, whereas from your perspective, John, you already know them or their family circumstances.
Yeah, usually that's the case. I must confess, backing it up even a little bit further, in terms of communication, I must be the oldest person in the room based by Lisa's introduction, and it makes me really a little bit challenged by technology like this. So I believe there's 70 of you potentially in the room, so hopefully our messages are coming across loud and clear to you there. How do you get that message across? Communication is just, again, I'm showing my age when I go back to the basics, and you must be authentic, you must be believable, you must be truthful, you must do as you say and say as you do. Personally, I reckon I fail the Penny Wong test or the Erica Betts test all the time. Hopefully I pass the pub test a lot more. As a GP, that's essentially basic contact with my patients is what I do day in, day out. and I just try and be myself, try and be authentic. And sometimes I'm dropping clangers all the time, unfortunately. But if I do it with good intent, you can get away with it. But true, the dot points are very important. But being yourself, being authentic, being a trustworthy person that they can relate to is so important.
I think from a rehab perspective, the easiest way is to actually ask the person, tell me about your story, what's happened to you. Yes, I can read about it on a claim form, I can read about it on an incident form, I can see correspondence between an employer and insurer, but by giving that worker a couple of minutes or half an hour to actually explain from their perspective what's wrong with them, what they think their injury is, what they think people's perceptions of them are, can actually help them have that time to build that trust with you.
Oh, it's a no-brainer to really get deep into the worker's story. To me, it's so often not just about the injury. The technicalities of it are what the insurance companies might look at. The detail might be what the lawyers argue over. But for me as a GP, the whole picture is what's so important. What's the story about the injury? Were there clashes at work? Was the worker in isolation? There's 1,001 things that can impact on that injury, and you need to do your best to tease them out as to the best level as you can.
I guess I find it a little bit easier because I have the opportunity of seeing that person in their home or in their workplace, and you can also pick up the non-verbal stuff and the environmental cues about what might be happening at home, what might not be happening at home, how they're interacting with their colleagues, all those sorts of things that you can also add to the story.
Sometimes the backstory is easy for me, sometimes it's a challenge for me. If I know too much about what's happening at home with a patient, sometimes that backstory is confusing when they come in with a stress-related claim, for example. Even just a chronic pain from a back injury can be influenced by the home situation. Our practice is a bit different. We do some enthusiastic sort of specialist workers comp from a general practice point of view for various companies. So we might see someone completely fresh from a certain company where we might offer a service, but we might see someone I've known for 20 years. And as that introduction of Lisa's might attest to, I've had the odd workers comp claim for someone I've given their childhood immunisations to. So sometimes that backstory is confusing, sometimes it's a blessing.
Also, I think it's important to use that same strategy as a rehab provider to talk to the employer about, what their perception of the issue is. A small employer who only employs, say, 3 workers and one of those is totally unfit, their perception and capacity to manage an injured worker is going to be very different than a larger company with 200 employees and a designated return to work coordinator. So it's always really important to try and grab everyone's perspective on it.
Yeah, I suppose harking back to to graduating in the 80s, it was very important for me, not being the most scholastic of doctors, to work out who was good in the room, and working out who were the best nurses to help me through the troubling intern years was very important. But the same thing applies with HR personnel in the workplace, rehab providers, working out who's good and who's value to help the progress of that injury is so important. So it's about the worker, it's about the work situation. There's so much in that story. The other thing to say is the story sometimes evolves, and you might get one version on the first meeting, but you'll pick up snippets as you go along. So it's not just about that first consultation, it's about what chops and changes over time.
Absolutely, and I think I'm just going to move forward another slide. I think the other thing is that you have to keep that communication going, and you have to constantly think about how you're going to change your messages and how you're going to change your communication depending on how that story is evolving. So you might have a message to deliver and you might have to think about, well, how you know, what words do I use? How am I going to deliver it? What time? You know, when do you start to deliver that message, particularly in psychological claims about, you know, when is it important? When is it just going to aggravate the situation? When is it relevant and when is it not?
Yeah, true. How you present that is so difficult. I mean, tailoring that message I find is really challenging as well. Again, trying to know your patient really well, whether you've known them for 20 years or 20 minutes, is so difficult. Verity's made comments here about a worker where English might be the second language. Well, their culture and background and education has such an impact on their psychological approach. We've certainly found down here some of our second language workers have some really interesting ideas on workers' comp. Their compass is sometimes different to ours too. If they've come from a concentration camp style environment where death and illness and corruption and bribery are commonplace, telling a few fibs on your workers' comp forms is not a major drama for their moral compasses. When they've lost family members, when they've been victims of severe abuse, we've just got to realign that compass with workers' comp. I'll never forget one bloke. He just had pain everywhere, and I just had to pull him up and say, "We'll look after you if you've got a sore shoulder, mate. It's not about you exaggerating what's wrong with you. You just tell me exactly what's happening, and we'll do our best to help you. You don't have to exaggerate or lay the message on thickly." And some of our people where English is the second language, these guys with their upbringing, they're unfortunately different and damaged, and we have to work with that.
It's not just English as a second language. I think we have to remember as well that there's a lot of Tasmanians with functional literacy and can read and write to the very basic of levels, but you can't give them large amounts of text because they won't read it, they can't. It's the same as when you send them text messages and things, they might not be able to read them. So you have to try and tailor the messages to suit that audience.
Having said that, I'd never underestimate the value of someone's antennas with poor written literacy. Their bull dust antennas usually work pretty well.
Absolutely, and their capacity to understand Dr. Google can be actually greater than their capacity to read documents.
Just as worrisome as their capacity to listen and be prompted by a long-term workers' comp recipient in the family. Yeah, so it's there are so many complicated things. I must confess that Challenger workers' comp I find really fascinating and interesting. Most of the time, but yeah.
And I think it's also important to understand that sometimes there can be too much communication, particularly in the early stages of psychological claims. I think people's space should be respected, and by contacting them every day or every second day, you're just going to feed into that anxiety or other issues that they're experiencing at that time.
Yeah, totally agree. Quality communication at the appropriate time is so important. Again, yeah, you can overdo it, but do it with authenticity and enthusiasm and caring. That's better than underdoing it, I find, but it's a challenging fine line.
And certainly the face-to-face communication makes it so much more valuable. You can pick up on the non-verbal cues and you can work out what you need to deal with at a later date if necessary.
Yeah, I find these non-verbal cues fascinating because it's easy for me because I've been working out of the same style of office for 30 years now, and all sorts of funny things will happen. Like in the waiting room, we used to call it Women's Day syndrome. Someone would turn up for an appointment an hour early and they'd read Women's Days. I suppose now you'd call it iPhone and Facebook syndrome, but just little cues like that are telling you that the person doesn't want to be at work and they'd rather be sitting in a waiting room. Those sort of sad observational traits are something we've just got to keep our antennas up for and be mindful of.
Absolutely. which moves us on to kind of talking about when communication can go bad with workers' comp. And I guess talking about waiting rooms, it annoys me quite a lot when I see rehab providers doing that initial assessment in the waiting room, waiting for the doctor. And more often than not, you know, they're trying to do this quick assessment. The whole waiting room is listening in, including me, and lo and behold, they've got a return to work plan already written. They haven't spoken to the GP, and they've all probably prepared the plan before they've even met the worker, and they've gone in to tell the doctor what to write.
Now, again, observing people in the waiting room, this is a fascinating flaw that you see with the rehab process. A desperate rehab provider trying to cram as much knowledge in the waiting room. Now this level of insult to the process, to me, by and large, the worker is slightly negative in their body language, talking softly, and the rehab provider is talking the most and talking loudly. So yeah, this just can't happen. I'd rather the two of them were on having a bit of Facebook time or reading a Women's Day, to be honest, because there's just no value in this sort of thing.
And I think it shows the wrong message to the worker that obviously listening to their story is not valued. There's no confidentiality to hearing what their issues are. And I just can't see that that's really gelling for a good working relationship.
Absolutely. If they're having a good yak about some topic they might have in common, or they're making small talk, that's nice. If they're building rapport, fantastic. But if they're discussing a claim openly in front of other people, that's an insult to their privacy.
Yeah. And I think as well, when people don't check in with how people are going, like as a rehab provider, not making regular contact with that worker to see how they're going is really, really dangerous. I was in a meeting about a month ago, and the claim was quite precariously placed at the best of times, but it was HR manager versus worker, and they were going hammer and tongs. It wasn't nice. And about 40 minutes in, the worker puts his hand up and he says, "You haven't even asked me how I am." HR manager very politely responded and said, "I don't need to ask how you are. I'm just paid to tell you what to do."
Oh.
So the meeting didn't go very well from there on in, but it could have had a very different outcome if it was just, "Hey, how you going? This is the purpose of the meeting today."
Yeah. Mm-hmm.
And I guess the other thing is, it doesn't happen very often, and I'm surprised that no conflict of interest is ever declared. And a lot of people know a lot of people in Tasmania, and no one actually sticks their hands up. So whether that's a barrier to the communication or not, I'm always quite interested.
Yeah, interesting one, because the conflict of interest, certainly our practice, we offer same-day service to a few of the big companies around us, and technically we've probably got some level of conflict of interest there, but we are pretty quick to say we value ourselves as an independent practice and independent practitioners, and we're working for what's a good thing and what's appropriate for the patient and the workplace, because a lot of doctors don't realise there's more things at play. There's the insurance company, there's the workplace, there's the worker themselves with the injury. But some GPs see themselves as the advocate for the patient and not the advocate for a good outcome. And those GPs that get on their high horse and just see themselves as advocating for the patient alone sometimes can be quite destructive. Is this the time I mentioned that herding GPs is like herding stray cats or something like that? Because we are a diverse group and we are a diverse mob. With my apologies in anticipation for the next time you come across one of us like that.
Mm-hmm. And I think there's this common misconception out there that workers can't see their GP independently, but I think it's really valuable for the worker to know that they can see the GP and seek their own advice without the rehab provider there. But in saying that, I also rely on the GP to be able to communicate to me if there is a problem, that we can reflect that with the return to work process.
An interesting observation there is often some of the loudest rehab providers in the waiting room are some of the first into the doctor's room to tell them what to do. Some of the guys I see with the most trusted relationships with the injured worker always stay in the waiting room till they're invited to come into the consultation room. And even if they're invited by the worker at the start of the consultation, they'll often just sit and say, no, have a few minutes with the doctor, call me in as soon as you want me there.
Yeah, and I think that just kind of builds that trust and rapport and transparency with all parties to show that, you know, there is some discretion there as well.
Yep, absolutely agree. Yeah, that it's a difficult role as a rehab provider. You just, you might have, if you're associated with that company as a long-term rehab provider or part of the HR team, maybe you've known that worker for a while, but you're getting to know someone for the first time. You've got to be so careful.
Yep. So obviously there's a lot of different aspects that you need to look at in terms of what's good for communication and how you build that forward. Obviously there's things that can go bad, but if you build a good relationship, if the inevitable comes and there is a dispute, at least you've got something behind you that you can then work on when the worker gets notice of that dispute. And it can either go one of two ways. You know it's coming and you can work you can talk to the worker about the dispute. You know, they've either attended an independent and the, you know, the letter says that they've wholly and substantially recovered. You're in with the GP and you can start to hash a plan at that point, or you're completely blindsided, you don't know what's happening, and the worker rings you 5 on a Friday night because for some reason workers only check their mailbox on a Friday afternoon, got a letter from the tribunal. So that's when you really need to clutch all of your communication skills that you've gathered along the journey to try and move that person forward.
Yeah, the dispute process is tough, and again, we do see GPs slipping in as advocates of the patient here. And again, it would be much better if we could bring any disputes into a very soft and slow landing. What I sometimes see with my patients is that they virtually develop a whole new friendship network with some injuries. Now that's not good, of course, but with a chronic injury, they get to know their physio really well. They get to know their exercise physiologist at times really well. They get to know their psychologist really well. And their rehab provider, if their rehab provider is really good, they become a professional friend in many ways. True, they're guiding that person through the process, but they're doing it in a collegial, friendly way. All these services just get pulled out from underneath people, sometimes over the space of a day or two, and they're just left hanging.
Yes, so ideally you get an opportunity to hatch a plan and work out how to transition that worker through, because obviously just because there's a dispute doesn't mean necessarily that the person's perception of their injury or their capacity just disappears straight away. And that's where it's really important to be able to have that relationship with the GP, with the employer, to start working, well, how are we going to keep this worker moving forward without leaving them in the lurch, so to speak.
Yeah, it's again, each claim is different. It's so often important to have everyone talking in the room. Some of these disputes, though, will backfire terribly. Ironically, sometimes, unfortunately, the GP may well get on a bit of a high horse as well here. Just dialing it back up even a bit further on, even as a comment from during the claim, we sometimes struggle in that we make that initial diagnosis and we try and stick to that diagnosis, whereas in reality things change during the claim. Then we move on from that changing diagnosis to a diagnosis where work isn't the substantially contributing factor, according to the what might be an independent report that the GP doesn't agree with. So then you've got a fair bit of negativity going on. So how you rescue that has to be good communication. and it has to be preferably a slow landing.
And I think that's where you've got to be able to give the worker options about how to move forward and how they can still access treatment, whether they can still access suitable duties as part of a return to work plan. Sometimes employers are able to offer that through employee assistance, and that really depends on how big the employer is.
If I waved a magic wand as a GP thinking about this subject, it'd be great if we could have a 2, 3, 4 week period to land the ship on these disputes. If we could get a bit of a wind down plan happening with that person's physiotherapist, a changeover plan with their psychologist, all those things would really help us in that work. Whether it's now no longer workers' comp and the insurance company and the lawyers can all wash their hands of it, that person's left with some form of injury, whether it's not necessarily work-related anymore, it's still an injury and there's still a lot of negativity to it. So to get the best out of that person, it also helps the workplace going forward to know that that person still has some level of care going forward. So this is a great opportunity to say to all you lawyers out there, if you could give us GPs and rehab providers a couple of weeks decent notice, and even a couple of weeks grace to land the plane without crashing before the runway, that'd be great.
Yeah, and also just to organise, whether there's community care options, can they transition to, psychology is the hard one, physio is a bit easier in terms of accessing community physio, but psychology options are next to not available at the best of times, let alone through Medicare.
Absolutely. Yeah, I think the psychologists are managing COVID far better than us GPs. They seem to have their no button worked out pretty well at the moment, and delays getting into good psychologists is are quite extensive in GP land now. The other problem I'm seeing is that we have Medicare options, which will allow Medicare funded support with a mental health plan for some people if there's a psychological injury. However, most psychologists, especially in Tasmania, charge 30, 40, 50% above what the Medicare rebates are prepared to pay. I could be here all afternoon complaining about the Medicare rebate in reality, but the psychologists are offered sometimes 50 cents in the dollar by Medicare to do the same work that the insurance companies respect and pay. Yeah, I suppose while I'm on the soapbox on that, I must confess I get paid twice as much for a sore wrist from Ingham's Chickens on Monday morning than what I do for doing a palliative care home visit on a Sunday night. So the Medicare system isn't kind to us as GPs, and it's definitely not kind to psychologists and less kind to physiotherapists. So you might think there's a system there, it's better than nothing. It can work, it's okay, but it's not a long way from perfect.
I think, Lisa, you had a question that's very closely aligned to this at the moment.
I've actually got a lot of really good questions that have come in. So, and the ones that I was going to raise with first was, Dr. Saul, you were talking a lot about GPs advocating for their clients. We have questions come in about how many GPs refuse to discuss the worker's condition and treatment with the employer, and also refuse to provide clinical information. It's quite often they won't provide GP records and they just won't have any contact. And I'm not sure if they feel like that's because they're betraying their client in a sense. But the question is how would you recommend that employers and insurers get around that barrier that some GPs have?
Yeah, that's a hard one. It's easy for me. I once really buggered up a certificate, and Graham Wood wrote me a very nice letter asking me in multiple dot points to explain it. So I just picked up the phone and said, Graham, I cocked it up, I'll fix it. So it's easy for me as a 60-year-old GP because I know a few of the local lawyers. I'm quite comfortable talking with them appropriately. I've got good relationships with a few of the companies I work with. But the GP footprint is changing. I'm probably describing why it happens, not necessarily how to fix it. But we get a lot of part-time GPs now. And some of our most challenged claims occur with psychological injury, and they occur with some of our younger GPs who are and excuse me, typecasting, but a lot of our younger female GPs can find themselves in really sticky, challenging waters where they work part-time looking after a psychological injury, for example. The lines are blurred as to what's happening at home, what's happening on the workplace, what's the cause and effect. It's not black and white. So a lot of GPs are prone to clam up there. I find the request for a notes dump as being totally valueless. They're valueless for me because the quality of my notes are atrocious. I'll say that on record, and it's far better to ask me for a clear and concise dot point letter. And if you ask me for a report, I'll do my best to answer that as each question is. And if you ask me quality questions, don't do any cut and paste with someone else's name on it, which I've had. I'll do my best to answer those questions. Certainly, any GPs struggling within our practice network, I tell them they've got to get those reports done and got to do them within 3 to 4 weeks as a matter of courtesy to the legal profession. Asking for a notes dump is a real risk in general practice, and we're even, some GPs are even being careful with the way they write their notes to not incriminate their patients long term. So I favour the notes dump, avoiding that at all costs, and go for a straightforward report like the good old days with clear and concise questions. As GPs, it's our role to be engaged and communicate appropriately. And it's disappointing to hear that you have some of these GPs doing this. If a GP is really clamming up, then it's almost worth taking it to to work cover as a formal complaint. And I'm just thinking about any reports that I've been a bit late and not as enthusiastic as I should be to write at the moment when I say that. But if a GP is doing the wrong thing and just not refusing to communicate at all, it's part of the workers' comp process that they should at least engage in some level of communication. The only second point in that is that GPs find it very blurred between information relating to the claim itself and information that they know about the patient that's not related to that at all. Like with psychological injury, for us to have to tell of childhood abuse or something like that, GPs will really struggle with the delicate line that they've got to tread there. So if I could ask the lawyers in the room to be delicate in the way they ask the GP for information, please.
Leading on from that a little bit, do you think then that there's a role for further training for GPs in relation to workers' comp matters?
Absolutely, that's an absolute no-brainer. It's a bit of an insult to the workers' comp process how little training we actually have in it. We work hard in our practice network to make sure that there are 3 or 4 of the 25 GPs in our group who are available to discuss workers' comp issues with all our patients, with all our younger doctors or any doctor who feels uncomfortable. So we try our best within our practice to have a bit of tea room and corridor support. But the training in the College of General Practitioners, for example, is unfortunately very poor. And this is a really important part of medicine. Where in TAS, we're so short of good occupational or any occupational physicians. We've only got a handful. GP training is so important, so critical, and any ideas out there to get us to the table would be great.
Cool. We had another one that potentially leads to or relates to the advocacy of their patients. but at times it appears that a GP may often have a certificate already written before a rehab provider gets to actually have a discussion with them about progress and return to work. How do you recommend that is dealt with, and by both of you probably being on different sides of that?
Yeah, total lack of training on the GP's behalf, total lack of understanding on the GP's behalf, and apologies on behalf of the profession to all of you out there who have had that done to you. Having said that, I remember a mate of mine called a rehab provider Dr. Such and Such because she always told him what to write on the certificate, so that can play both ways. It's totally ridiculous to have a GP writing the certificate before the consultation. Totally ridiculous to write it before discussing with a rehab provider if the rehab provider's there. I suppose I get back to the fact that a good quality rehab provider here is a quality purchase. The cheapest thing is quality when it comes to rehab providers. You might get some companies I've seen at times, they've gone with a certain company for everything. If the quality of rehab provider is not within that company, then the process will fall down. So often, if I could handpick my rehab providers, I'd do it every day.
Good. I just have a few more questions going back to the dispute process. It appears more common now, I've noticed with some of my clients, that instead of just throwing a dispute on the worker, they will actually ring them and let them know what's happening. From a GP perspective, is there anything further that you think you've already touched on this, that time would be very helpful? Is there anything else from that point of view that would assist with a notification of a dispute?
I must confess, the lawyers in the insurance companies and the rehab providers often give us some subtle hints, and we should be acting on them and potentially getting our patients ready for it if we get the chance. I mean, the second and third independent medical often gives us a bit of a hint that something's on the go with you guys. Sometimes the delays in processing of independent medicals sometimes tells us that the insurance company either likes it or doesn't like it. So I must confess, a good GP might have his antennas up that something's going to happen and prepare their patient. But other than that, we're just blindly trying to get them better, and we're trying to stay out of the legality of it. And unfortunately, we get drawn into it when the crash comes.
Another question that sort of leads on from that, as a GP, if you have a patient that's come in and they're looking to make a stress claim that they're attributing to action taken by the employer, do you as a GP see it as in the scope of your job, it probably isn't, to inform them that there is a possibility that an employer will dispute a claim, or do you feel like that's not your role?
I'm quite comfortable trying to describe the process in my experience. I'd just describe it as an enthusiastic basic GP, and certainly with stress claims you often see disputes, so they're often mentioned. I personally often use those wonderful words to other doctors asking me for advice, and also to my patients. The question's going to be, what's a substantially contributing factor to why you have a stress claim? And if you've just lost your husband and your son's a drug addict, then be prepared for some of this other stuff to get drawn in, whether you like it or not. And I think an honest and frank conversation every GP should have when it comes to stress claims. Again, what's awfully challenging is someone might come in with describing symptoms of anxiety and depression on a 15-minute appointment, and 25 minutes later they say, and doctor, I think this is workers' comp. And you're just left with another 25 minutes of discussion, trying to wade through the workers' comp nightmare. Again, it gets back to good, honest communication. I do advise people that if there's any chance that work is not the substantially contributing factor, that work have the right to ask questions and take it to dispute.
I don't think your presentation is finished, so you might, if you want to continue, we can, unless it is. I think
we've kind of covered that last slide, unfortunately, and I didn't flick it over.
Oh, right.
Yeah.
All right.
Can I just
That's
say,
all right.
Lisa, when you were talking about, like John answered in terms of the GP preparing the certificate before you get in there, from a rehab perspective, there are a couple of GPs that will consistently do that. Most of them don't, but that always pricks up my antennas about what's going on here, and that always then precipitates another discussion with the GP offline to ask from their perspective why that's happening. And quite often it's the injured worker pushing an agenda, unfortunately, that they're directing, you know, that these are the only duties available or whatever, and the GP is completely blindsided about the fact that there are other things going on.
Do you see it common? Sorry, no, continue.
Oh no, that just again, there are so many factors at play here. Is there a problem with the rehab provider from a GP and patient point of view? The clash with the rehab provider, or a rehab provider that seems to be overstepping the mark according to the GP and the patient. Sometimes they'll go off piece a bit when that's occurring. But again, cheapest thing is quality when it comes to rehab providers. Please, can we have the best quality rehab providers who will subtly guide us when we've lost our way as GPs? That'd be great.
One thing you brought up before was people often exaggerating genuine claims to feel like they would be better believed. Is that a common experience, that they just don't feel like they would be trusted and they need to exaggerate what is already a genuine claim?
As soon as they say trust me,
never trust anyone who says trust me. It doesn't happen that often. It often depends on what level of support's within the workplace as well. Certainly when there's a good employee assistance program or a flexible workplace, we see some big changes in terms of that level of presentation. If a worker knows they're going to get a little bit of physio, they might tell you that they fell over in the pub on Friday night and not claim a back injury that they didn't disclose on Friday morning. They might tell you that they pranged the dirt bike on the weekend, knowing that they might get a little bit of help. So certainly companies, large or small, who offer support for a good worker who comes unstuck, you don't get those blatant and obvious rubbish claims. Again, it's about relationships. If HR and the workplace have that relationship with a worker, you get a fantastic level of honesty. We certainly as GPs try and put ourselves in a position of assisting that company as best we can. And again, the yes or no answer about a workers' comp claim is often very difficult in the early stages of a claim. And where GPs dig a hole in for themselves, digging into a certain diagnosis, that can be a negative thing in itself. But having flexibility and openness in any claim to be able to turn around and say, well, I think this is related to long-standing osteoarthritis and not really related to the work injury anymore, to have that ability for all parties to accept that but still be supportive of the worker, I think is a fantastic thing. So it's not just about the adversarial nature of a dispute. It's about bringing that plane in for a soft landing at the conclusion of a claim.
I've just got a few more really good questions in. About 12 months ago, following Chief Commissioner did a seminar in one of these masterclasses. The Tribunal launched an initiative providing an information sheet to workers in relation to disputes of their claims. Have you noticed any positive difference in response and level of understanding in workers since that time?
I didn't know that there was a sheet like that, so I've never seen it. And normally when there's a dispute, someone will come and see me with 40 dog-eared pages that have been through the bush backwards, you know, all muddled up. And I can honestly say I haven't ever seen that.
The next problem, and no disrespect to documents with a legal tinge, is again, they're very hard for your basic GP to understand, and so they represent quite a challenge for a factory worker or a tradesman to get their head around. Yeah, I must confess, even the letter calling for a tribunal review is steeped in legal speak and can be quite confronting. And some of my language to a patient is, well, we've got this letter. Sometimes it's just the insurance company and the workplace wanting to know more about your claim.
Yeah, and I think even just the very basics, when they get the letter and it says that their employer is disputing it, a lot of workers get quite distressed with that, not realising it's actually the insurer of the employer that's disputing it. But it's just the way the legislation's written that it's the employer that's disputing it, and that's quite heart-wrenching for some workers.
Absolutely.
Yeah.
If they're a long-term employee, they feel like the employer's letting them down by challenging their opinion of events.
Mm-hmm.
So unfortunately, the legal documents, they need to be precise and legal from the point of view of the process, but they do present some challenges.
Have a couple more, Dr. Saul. In the case of psychological claims, what guidance can you provide in relation to the approach in providing copies of IME reports to workers where you suspect the content will have a negative impact on their condition, particularly where it's probably going to be served and relied upon by an employer in disputing a claim?
Yeah, again, I certainly in my practice, I try and read the report as best I can. They can be challenging and difficult to actually understand the intent of them. The patients themselves will swing on a paragraph they feel is not right and not on the content of the report. The tricky thing there too is that a fair few reports vary wildly in their description of events, and they can be quite inaccurate factually as well. The other problem I see is that tendency now to psychiatric evaluation by telehealth, which I find very difficult. Now we're challenged to get good specialists in Tassie, especially with our border closures, and relying on telehealth. I'll never forget hearing of one psych assessment that was done over an iPad, and this guy can look cool as a cucumber with his facial expression, but you don't see his leg twitching or his hands fidgeting when you're on an iPad, and you just don't get a clear picture. So unfortunately, trying to communicate what's in the report, especially with psychological injuries, definitely I need to read the report, and definitely I need to see the person face to face. And it's a bit like breaking bad news. You've just got to be so careful the way you do it, because it does result in anger and frustration quite a lot of the time.
From your experience, to what extent are general practitioners guided by the IME reports? If they make treatment recommendations, are they implemented?
Yeah, they're usually treatment recommendations that are based, well, I'll go on the average IME report, which is by and large usually a very good document and a very good assessment. I've sprayed a few IME reports in my time, but the reality is they're quality, usually quality people writing them. So I personally try and implement any recommendation that comes through, even if it's just to see whether it works or not, to say yes or no to an insurance company that might favour me exploring factors in in the IME. But usually you don't find any new treatment options that haven't been tried already before. To be honest, a lot of the IMEs, they fall onto that side of the pendulum that whichever side, it's more just an opinion of yes or no on the claim. We don't often get that much in terms of recommended activities by the time they come along.
Verity, this is a big one. What have you observed to be the single biggest factor in successfully getting a worker back to pre-injury duties and hours with an employer?
Single factor? Wow.
The single biggest, or a few, if there are a few.
Look, I think it's that very first kind of working out what the issue is, and John touched on it. It can be a back injury, but there can be so much more going on in the background. And I think you need to kind of unravel the layers of the onion and work out what is workers' comp and what is the compensable injury. But my goodness, sometimes I do have to deal with a couple of other issues on the side to get that person back to work.
And I am sure it's your experience that the longer they're out of work, the less chance they're going back. So
absolutely. And yeah, if I can get them back as soon as possible, that's really good. I think psych claims are probably the hardest in terms of all the other issues that are going on. And I think sometimes you can resolve it quite quickly. If they have no intention of going back, they don't want to do mediation, they don't want to talk to the employer, sometimes hearing the story and it's as simple as, you know, I just want to go and work somewhere else, and you can say you can sometimes very quickly deal with that claim and get them back to work at a different employer, and the claim resolves quite quickly.
So I've noticed in my experience a lot that the bad communication can lead to them not coming back to work as soon as they may have previously, and in fact exacerbates the problems. But as I think you guys mentioned, it's a fine balance between, I've seen many claims where, the employer doesn't care, they haven't contacted me, but I've also seen the flip side where, the employer's harassing me. So as you guys said, it's trying to find that fine balance in the middle.
Yeah, and I'm happy to call the worker out as well. So if they say the employer hasn't contacted me, and I can say, well, I know they've sent you a couple of text messages and you haven't responded, it's always interesting to see what their response is. Or, you know, have you tried contacting the employer? Have you tried going in for morning tea? Always try and get someone to go in just for a morning tea or a social event to get them back over that threshold to start that process again.
Yep. We're almost at the end. Is there anything further that you guys want to finish on?
I suppose leading on from what Verity said, it's incredibly complicated and there are so many factors at play here. What's the single biggest thing to make a claim work? It's usually 5 or 6 things working together that make one thing work, make the one big thing work. But there's often so many odd little unique points that'll help a claim, like certainly with extensive time off or reduced hours, some people develop a whole new network in their activities, and a classic for again, I'm typecasting here, but a female factory worker, for example, might suffer from ugly husband syndrome in that there they are working full time, they get a shoulder injury, and they're on 4 hours a day. It gives them an extra 4 hours a day to prepare a meal for an ugly husband who wants it on the table. He's quite happy to take her income and spend it at the pub or buy a new ute, but he also, she's under pressure to be a mother and a wife and also work full time. An injury is a gift to someone like that if they're on reduced hours or off work. So we've got to look at every aspect of every injury and try and find a solution to each problem with it. It's not just about the shoulder injury and and fixing that sometimes. We've just got to look at every facet.
And I think that's a good point, because some people don't ever spend that much time at home, and there can be quite detrimental effects.
Yeah, I'm showing my age. We used to call it Days of Our Lives syndrome. People get used to going home watching Days of Our Lives. So thank heaven for Netflix. You don't have to blame Days of Our Lives anymore. But I had one grandmother who was picking up the grandchildren from school at 3 o'clock. So her return to work suddenly revolved around helping her daughter out, picking up the kids from school. And it's totally ridiculous to think it should impact on a workers' comp claim, but it does.
All right, well, thank you very much. That was very informative. And again, we thank our sponsors, HWL Ebsworth, IIME, Red Health and LKA Group, and of course our wonderful speakers, Verity, Coulter and Dr. John Saul. Just a reminder that next week is the final Masterclass seminar with the Chief Commissioner, Alison Clues, at 2:30 p.m. on the 26th of August. And we then have the cocktail party on the 3rd of September. Again, a recording of this webinar will be emailed to all participants for a viewing of 2 days before being put up eventually on the AELA website. Just a quick plug for upcoming seminars. You can see those on the screen, and the national conference. We'll leave that one for the moment. And anyone who's not a member, please join us. Thank you very much. Thank you so much for presenting, and we can sign off now unless there's anything further that you two want to say.
No, all good. Thank you.
All good.
Thank you so much.
Thank you.